the patient side, you've got currently engagement tools that are, starting to become more and more accepted, adopted, where it allows the patient to engage with the office for an appointment, or whether it be for instructions on an upcoming procedure, ways to pay on a bill, or view your account. So that's becoming more and more prevalent as far as availability. The adoption of it from the patient standpoint might not be as fast. They still have the choice not to use that way of accessing. From an RCM standpoint, near and dear to me, it's, how can an office get a patient to be more the probability of getting them to pay, right, promptly, or in an affordable way, that whole compassionate collection terms that you hear now. But I think that there's room for improvement. I could start going into a lot of things about what is the practice or the RCM director's hesitation to adopt some things, because I can tell you, I still see and hear, especially when I was doing my consulting, the departments or people within the department hesitant to put patient credit cards on file. Let's use that one. Honestly, in a smaller setting, the physicians who are the owners or have a lot of decision making, they do not feel like they want to go there. It's like, let's not insist on that. Now for the practices that have adopted it, credit card on file, there's just a whole nother conversation for that later. But I don't think they would ever go back. So that's the patient side of it. It's really the willingness to adopt it from the patient standpoint and even the practice standpoint. But again, I think that technology is improving more and more to make the ease of it. We'll take the automatic sign-in, for example, the iPads. Everybody knows that there are some brands out there that allows a patient to check in using that. Has its advantages. Practices still are, balancing the is it worth it side of that, because the people who, especially the elderly, you still have the Medicare population that is not going to use it correctly or understand it. So they end up back at the front desk anyway, those kind of things.
Yeah, well, I got to say, so coming from the technology perspective, the reality of the technology being used by all the different parties, and we'll focus more on the provider side, because that really, the RCM director is kind of our hero in the story, and we want to make sure that that they're equipped with the best knowledge they can be to make the right decisions as they're trying to go through a digital transformation. So the technology, unfortunately, that they're being forced to use, typically their EHR is kind of the front door for everything. It is pretty bad. I've sort of got my long list of complaints about how EHRs were essentially created to take advantage of sort of a subsidization that we did from the government back in 2009 timeframe to sort of bribe all the doctors to use EHRs, which then resulted in all the EHRs getting created and then all of them being sold to private equity, and then none of them really being updated. And it's like the current version of when you go to the airport and the person behind the counter is there typing and typing and typing and typing. And you're thinking to yourself, what are they still typing? And the reality is they're working on top of a system that is still running on decades and decades old technology, maybe with a cleaner interface, sort of. The same thing is happening on the EHR side. So, whether you're the patient trying to register, and you get the clipboard, or you have to type in the iPad to enter the answers to the same questions you already answered last time, or that you've certainly answered to your, health insurance provider and everyone else, all the way to when you're in the visit and they're not looking at you, they're looking at their computer screen to try and select the right drop down and check all the right boxes and do all this different stuff, and then type a bunch of content out that you then get a printout of when you leave that is, sort of jammed full of material, and only a small section of which is actually helpful. And then, this is all in support of the claim going to coding, to get, can we maximize the diagnosis codes to increase the risk score? And then can we make sure we capture every charge? And if there's an opportunity to level up a charge because, gosh, it was a situation that warranted it, let's do that. And then out to billing to say, well, is this payer going to pay this claim with this modifier plus this diagnosis code? Oh no, we have a special weird contract we signed last year that means for this payer we have to do it differently, and somebody's supposed to remember that, or in theory software is supposed to help with that, but in reality it doesn't. And the claim goes out the door. Oftentimes it gets paid as expected, but for the 15 to 20% of the time it doesn't, that you have to touch the claim again in the accounts receivable department. You might be disputing a claim that was denied, or you might be correcting a claim where you didn't make that final tweak before it was billed, or in some cases you have to appeal and include medical notes, and that's where you're going to want to have sort of that robust body of content that was unhelpful to the patient then became in support of the appeal. And so often, we're seeing this where you have sort of everyone's practicing a defensive medicine in some ways, over documenting every single thing so that they can win an appeal that the insurance company is forcing a office to go through. All of this is complicated just naturally, and then made more cumbersome by the tools that they're forced to use to do it, which ultimately results in sort of burgeoning AR problems, repeated unnecessary unforced error denials, multiple touches when a single touch could have happened, and the need for more staff, and then bolt-on tools to sort of supplement the bad software, or a lot of Excel ninja skills. And it strikes me that sort of the RCM director, sort of sitting in the eye of the storm here, is forced to make so many compromises on how they would like to do things because of the limitations of the tools that they use, and that they have to jump through a lot of hoops or throw a lot of bodies at something. Maybe their software doesn't do auto posting and reconciliation correctly, or maybe their software doesn't do patient billing in a meaningful way. And